with the Sharp Index, and I'm sitting down with leaders in healthcare. I'm really excited today to hear from you and to talk about the future of artificial intelligence and technology. And I'd love for our panelists to introduce themselves, and then we can go straight into current events. Stephanie, do you want to start?
Sure. Really excited to be here for this discussion. Stephanie Lahr, I'm the CIO and CMIO at Monument Health. We're a not-for-profit healthcare system based in Western South Dakota. I'm an internal medicine physician by background, but spend all of my time now at this intersection of healthcare and technology.
Awesome. And Ray, you're from a different area.
Yes, well, good morning, and thank you for including us. So I'm Ray Lowe. I am the Senior Vice President and Chief Information Officer for Ultimate Health Services here in Los Angeles, California. We're a large Medicaid, Medi-Cal provider. So we basically serve the low-income, non-English speaking patient population in the inner cities of Los Angeles and Orange County. I've been the CIO for about 4.5 years.
Jared, do you want to tell us about your work?
I'll round us off. So Jared Pello, I am the Chief Clinical Product Officer at Nuance Communications and Microsoft for Dragon Ambient Experience. And so I've been working in this field of AI and how to help physicians for the last 8 years. I'm an emergency medicine physician by training, and like Stephanie, not practicing currently, spending all my time trying to figure out how to better help our clinicians in the field.
So everyone's a doctor. Is it okay if I use first names, or do you have a different preference?
First name's great.
Okay, good. I'm not a physician.
I play now a doctor on a TV series, but I'm not a doctor.
You can do that. But I'm excited too about the diversity in terms of types of patients that everyone serves here and types of payment models that are used, because maybe we can discuss some of that. I know with technology, I love technology, but it can also be a shiny new toy. And I really want technology to be something that's an asset. A lot of physicians and a lot of healthcare systems see it as a giant administrative burden or something that doesn't bring them joy. So I'm sure you've experienced that. And during the last few years, opinions about physicians and the way we talk about technology, it's really changed. And the pace of adoption has also drastically changed. So I would love to get your opinion about that. Like what expectations have changed, and what does your organization see as important? And what's top of mind? So Ray, maybe you could start.
Sure. So I think you're kind of saying that's a nice question with the pandemic in the rearview mirror. I mean, you go back to March 2020, where we were in our technology journeys, and some were more advanced than others, some were catching up, and some were way behind, right? So we really had to pivot the organizations, right? There was no admitting, everybody was sheltering at home. And so the technology shift, a lot of it through the virtual visits and televisits that many of us, we, for instance, had no platform to move forward on during the pandemic. And we had to stand this up really in a matter of a month to meet the patient need, as well as symptom checkers, right, during the middle of COVID. So I think in that time period, there's been a big lift, right, in kind of closing how we can meet the patient where they're at, giving them tools for more self-diagnoses around there. I think kind of where we are now is we're now splintering more different prioritizations that are coming back more local to your health system and your market and your needs.
Giving someone a useful Dr. Google.
I'm going to take maybe a slightly different slant on the question. I think back to the early part of my career as a hospitalist, and I remember during the interview, I was already using an EHR across our full system in my residency training, but that was still relatively early in that. And I went to interview with the CEO at a small health system where I was at in Northern Idaho, and I asked about EHR, and he was like, "Are you a doctor asking me about a computer? Like, the only thing I ever hear from doctors about computers and technology is get it away from me. And I had my own experience that had led me to believe and realize this was absolutely essential to our future, but I was totally willing to admit it wasn't where it needed to be. And that really is where my career began in this space, because I thought, well, it is not going to get any better if I don't participate in that improvement. And so, we spent a decade putting tools in that people didn't want, didn't feel were helpful, didn't need. We can argue about whether, that was right or wrong, but at a minimum, it's done and it created a foundation. During that time, a lot of the conversations were around, why are you making me do this? Is there somewhere I can go? And that was a completely reasonable thought, because in many cases, we were just making their lives harder. And it wasn't just the technology that was doing that. It was the way we were using the technology. We were using it often as a stick, as a way to meet regulatory and other burdens that previously we really didn't have a great way to legislate to people. And now suddenly it was like, oh, you mean you could hard stop that and keep them from not doing it or from doing it? Great, do that. So fortunately, we've started to move past a lot of that, but the baggage of that is still with us. And so it is totally legitimate right now that a lot of our providers feel like technology is a burden and are wary when we come forward and say, we've got this great new thing. And they're like, I've heard that before. The fun part is that with products, like DAX and others, when we show it to them, they're like, oh, well, wow, maybe this really might work. And this almost works kind of a little bit like my phone, right? Because everything should work like your phone. And so we're getting there. And now it's actually a much better problem to have. More and more of our clinicians are coming forward and saying, okay, I get it. Technology is where the world is going, and I use it in my all the time life. Let's use it better in healthcare. And so a lot of the days of sort of saying, I don't want to do this, we don't hear that very much anymore. And this is a much better problem to have. They're saying, how can we get better, faster? What can you do to remove the friction in my day-to-day life? And to your point, my mantras are, I'm going to reduce the friction and bring the joy back to medicine. I can retire when those two things have happened.
That's great. I like the acknowledgement that this has been a process. And Jared, you at that time moved into technology. Is that correct? Like the timeline?
Yeah.
So what do you think about that?
Yeah, and I think it's actually interesting to think about the timeline a little bit. If you think about when the HITECH Act, meaningful use, when that all happened, it was about the same time as the iPhone coming out. And so while on the consumer side, on the other part of clinicians' lives, they were experiencing this new technology that fit in their pocket, that could do all these things. They started getting this technology in the office that was slowing them down. And for most, would cut their productivity by 30%. They could see 30% less patients, or they were spending that much time at night taking care of the documentation. Mm-hmm. And really it was somewhat soul-sucking for them, for us, as we spent time doing that instead of actually doing the healthcare that we wanted to deliver. And so it was a really interesting time to be building new technology and say, can we deliver something that's actually kind of magical, that is almost kind of like an iPhone experience, like when the first time you picked it up and you're like, oh, this is neat, I have everything right here. Can I deliver an experience to a provider where they're like, oh, I can just focus on the patient, I can just focus on the healthcare I want to deliver. And it's an interesting kind of transition, like Stephanie said. We're seeing this change though, where providers they're accepting now the technology is the path forward, and they're starting to catch the vision also and come forward with ideas. And we see more and more physician leaders like Stephanie, like myself, stepping into roles and saying, we're going to actually work on this hard problem and try to solve it together. And we need great partners like Ray and like yourself in helping us.
Yes, I like that you need the technology. And that leads to a great point. Health system leaders are coming from this history of lots of regulations, which is super fun, and an administrative burden, and technology that was designed with different aims. What do you see as the challenges, or what have you done to reduce that burden or to bring that magic that Jared's talking about? Stephanie, do you want to start?
Sure. So, I mean, I think you can break this into lots of pieces. Workflow optimization, which with technologies that people already have, you know, your EHR and those other kinds of things, all of those companies are working on tools embedded within their own structure that can help people be more productive. If you're not taking those updates, if you're not then also having teams of people who specialize to an extent in bringing those into the workflow, figuring out team structure, re-examining whose responsibility is it to do what, figuring out how to help people get to top of license and taking more mundane tasks and pushing them down the rungs. Those are things that everybody can do, and probably are things that you can do with technology, again, that you already own. Then I start thinking about automation. And I think about that again from a broad sweeping category. So, you know, we have a number of providers that are on DAX. That's essentially a way to automate clinic-based physician documentation, right? I can have an interaction with my patient and the note will write itself essentially. And, you know, asterisk, we can talk about the details later. But that removes that friction. But there are other things for the staff out at the front desk, for the nurses and all of those kinds of things that we can reduce friction for them with automation of tasks as well, leveraging a variety of different kinds of technologies. But a lot of the things that people are doing that are repetitive, we now have programs and there are softwares available, technologies available to be able to figure out ways to then automate those things. And that's in clinic and that's in the hospital. That's with your revenue cycle teams and your HIM teams. Like, nobody wants to be doing what they feel is low value, monotonous, repetitive work. And if we're paying people to do that work, there's no more expensive way to get that work done. So then it's figuring out how to get the investment in place, which is upfront, to create some of the automation so that you can do more with less.
Yeah, that's a good point. Humans are not great at repetitive tasks. That's not our strength. Ray, do you have any comments or thoughts about workflow?
Yeah, so being a non-physician on there, I tell my executive team that it's 15% the technology and workflow, and it's 85% of the people in there. And I often find times we're on Epic, and as we're continuing to say more patient engagement type of activities, leveraging more of my chart in there, and then it drives other questions to the patient service center, or where they're not quite ready to react. So I think we have to do not only train up, but train for competency. We're looking at within Epic integrating a training tool that gives instant help, because we can go and train through different cycles, but if we're really going to elevate the overall experience for all users, you know, of the product, and they're stuck or they may not understand it, and I don't think people like to identify, I don't understand, right? They'll kind of just keep going or kind of ask a friend or kind of go down a path. So I think that's kind of a change moment. But on the physician side, the way that I look at it is it has to be easy and it has to be efficient. Stephanie said it has to be as easy as my phone, which I agree. So I actually put a lot of the applications on their phones for them to use. But they don't use it all, right? And we've changed out video clients as well to make it easier. We've done other things around there. So I think on on provider productivity, again, it's kind of like consistent communication. What are the top 5 things that we're doing in our grand rounds? What are we educating them? How are we training them on there? The automation is definitely where we need to go to. Except Dr. Lair is ahead of us, on that journey. We're doing more automation, say more on the supporting departments of HIM and trying to reduce that friction so that the note comes back in for specialists, et cetera, back to the primary care provider when they're providing the care. So there's lots of opportunities that can be done within there, and kind of personally, when I last saw my PCP, and there was a scribe in the room, and I'm like, I'm a pretty advanced IT guy. I'm pretty familiar with it, but I still thought it was a little bit obtrusive. You're having a personal moment with your doctor, and she's telling me, well, I'm going to spend all my FaceTime with you. I said, I get it, but then they had a scribe and a scribe trainee, and I don't know, it's because I'm an IT executive and therefore it should be okay. But I think about what does the patient want in the experience, and how comfortable does a patient want to be when you're really sharing your personal information with your most trusted person, right? Your doctor may know more than your significant other about things. So I think there's opportunity rather, but we kind of need to look at the holistic side of it, but we really need to make sure the providers can deliver the care appropriately.
Yeah. You said a lot, and I have a lot of thoughts, but I also wanted to give Jared a chance to talk about that. Scribes, or about what you've seen in terms of workflow changes. Like, do you have any stories?
Yeah, I mean, there were lots of great things. And I like that both Stephanie and Ray, you guys both called out the experience, not just for the physician, but for other people in the clinic, clinicians, whether that's MA, nurse, front desk people, and the patient. And I like that ratio that you gave, Ray, that it's 15% technology and 85% human. And I completely agree, because what we've seen with DAX, so some physicians love DAX. DAX records doctors and patients talking and then writes their notes automatically and then has it checked by another human being. And then it's placed back in the EHR for them. And Ray can't use us because we're not in Spanish yet. And so, or we don't do mixed languages. We don't do English and Spanish. But what we've heard from physicians is two things. One is just this immense lift of cognitive burden. Is they start talking about, I get to focus on my patient, I get to focus on their nonverbal cues. And I think that's the 85% that they find really meaningful about medicine, because medicine is pretty repetitive, especially depending on the specialty you're in. Now, for myself as an emergency medicine physician, for Dr. Lars is an internist, like we have a little bit more variety in there. But some of our specialist friends, like they see the same thing every day. And it really comes down to the interaction with the other human being that is really interesting to them and that they really thrive on. And by allowing them, taking the technology out of the way so that they actually get to spend time doing what they love, connecting with people, taking care of people, that's really kind of a special thing. And so that's what we'll hear is like, I'm connecting with my patients like I haven't in years. And then the other is like, I remembered I have a family, or, having a spouse tell us that they want to send us a Valentine's gift. They're like, I think you saved our marriage. I want to send you guys a Valentine's gift. And so that is the other thing, is just knowing that physicians have lives outside of the hospital, outside of the clinic, and we want to allow them to connect with their loved ones a lot as well.
Yeah. I'm always reminded when we talk about scribes and this technology of a story. My dad is an attorney, and he was a hunt and peck like person. And so he always had dictation software, back before it was everywhere. And he always taught us, do what you're good at, and had this very strong lens, like an attorney father, like, well, that wouldn't make sense with my billable hours. and I realized later in life that people aren't always making decisions based on those billable hours, but a lot of the time in healthcare too, we are wasting time, and we don't really have time to waste. And I was thinking about some of the stuff you said about access and about freeing up physicians and patients for things they care about, maybe we could talk more about that. Like, what does that mean? What does that mean for healthcare access? What does that mean for people in your population, right? Or yours, Stephanie, where South Dakota doesn't have like a billion people.
You don't even have 1 million people. You were totally right.
Okay.
You don't even have to throw out the B, the M. I can't even get to an M. Now,
Okay, good.
This week is the Sturgis Motorcycle Rally, so we'll crest 1 million for about 8 to 10 days, but that will be it. But no, I mean, it's a great question. I love living here. I know a lot of people who do. Physician recruitment is challenging everywhere. We just don't, provider recruitment, our APPs, nursing recruitment, all of our clinicians, we are in a shortage of right now. And I don't know why, but not everybody wants to live in the Black Hills of South Dakota. And so, I mean, access is something that we talk about all the time. And if I can, physicians will say, I don't ask me to see one more patient. Well, the reason they're saying that is not because they don't want to see the one more person. It's all of the stuff that comes along with that one more person. If I said to all the physicians in our health system, hey, tomorrow, see as many people as you want / can, don't document anything, don't, the orders will just happen miraculously. There will be no administrative burden. No one's going to bring you an ABN. No one's going to bring you a prior auth. No one's going to just see the people. No one would say, I can't see one more person. It's the people part of it that they want to do. It's all the rest of the stuff that makes them say, I can't see one more person. And so that's where I feel like it's, our job to go in and say, what's causing that level of friction and what are the things we can pull out of it. I think also what's interesting though is we need data more than ever. We're going to crunch as much stuff as we possibly can so that when Ray comes in for an appointment and I come in for an appointment on the same broad topic, I will get care that's better for me and he'll get what's better for him. And if I come in South Dakota versus, him being in California, there are factors that influence, the kind of care and the kinds of treatments that we might want to do. And it's going to be data that's needed in order to figure out those nuances. And so the tricky part is we have to keep all of the inputs. In fact, we probably need even more inputs than we have today. So the data is going to become more and more important as we make these transitions to more personalized care. So we're going to need more of it, but we can't do it on the backs of our clinicians. We have to do it in other ways. And I think that, again, is going to create access. An interesting thought, I got asked a question on a recent panel discussion about behavioral health and how some of the elements in moving technology could impact access. And I thought, well, it's a bit of a string together, but right now, the average patient who needs to be started on psychoactive medications for depression or something will go through 2 to 3 iterations of trials of medications and associated appointments with a provider in order to actually get to a therapeutic medication that is going to be right for them. As we move into precision medicine, and I can take what I know about Stephanie, phenotypically, genotypically, all kinds of ways, all the things I know about her, and say, gosh, with 80% probability, this medication is likely to be the best one for her. That actually just created access, because those 2 follow-up appointments where I come back in and say, I'm not where I need to be, won't happen. And now those appointments can be taken by people who need the access. So, I mean, access, I think, is central to a lot of this automation, because it's not just about, yes, I could probably see 15 people today instead of 10 or 40 instead of 20, but it's also how do we think about leveraging technology and all of the things that surround it, data and other intelligence that would allow us to better care for people so that we aren't doing this repetitive revolving door as well.
Right. So Jared, you have that solved, right?
Well, what I love about that is thinking about how precision medicine technology data is going to free us up. And it's not only going to make it so that that patient doesn't need to come see their doctor 2 more times, it's going to make them more compliant, right? Because they're going to receive an effective treatment the first time, or more likely to receive an effective treatment the first time. And I even kind of hate the term non-compliance. It's not that patients don't want to be healthy. They don't always have the education they need. And sometimes they're receiving a treatment that isn't helping them. And so using data, using technology, genomics, all of those things to help us deliver precision medicine so that they're actually getting the benefit they came to see us for, I think that's hugely beneficial, and capturing the right data is at the core of making that happen.
Yeah. So Ray, I really want to hear your opinion too, because you're in a space like the FPHC space I care about a lot.
Yeah, it's an interesting, it's very interesting kind of point of view. And I'm very honored to be on a panel with Dr. Lair. I'm a big fan of hers. I think she's one of the smartest leaders out there, period. And so for UltiMed, we serve almost 400,000 lives. Most of them poorly educated, 200% below the poverty level, non-English speaking, and really like in a 40 square mile area of Los Angeles or Orange County, right? It's when you go more on the inland areas around there. And so this is kind of like talking about the real shift from volume to value, right? So when we went live with Epic prior to, I think our providers were seeing 13 to 15 patients a day, right? Now they're seeing 23, which is kind of that benchmark that you look at with a good performing org, on Epic. And, but the other part of it, right? When you look at how do we encounter the patient, and this is again, the volume to value question, and Stephanie brought up, people practicing at the top of their license. So the doctor doesn't have to be there or see somebody for a hypertension check or other things that could be taken care of by a different provider. And let's talk about kind of the data, since Dr. Lair brought that up. If we kind of know what is a chief complaint of the patient coming in for the visit, and the intelligence tells you have these kind of like a routine follow-up that could be handled by an RN or somebody else in there, and then it opens up the physician's schedule, right, pulling out 4 of those for somebody that really needs to see the doctor, right, from a primary care perspective, real time. I mean, I think that's such a game changer. They're being very precise to the individual. And I'm kind of saying, how do we create the more value-based and quality-based availability of spots in a very dense, volume-driven business? So that's kind of my lens on how we can work through this and kind of look through this and kind of change the paradigm. The other portion I'll add as well is an ease for physicians. Again, because we have so many languages in Los Angeles: Spanish, Mandarin, Tagalog, you name it, right? The health plans require us to communicate in 15 different languages at least.
Oh.
And so when you encounter, patients that are non-English speaking, we all know you can't go through the kid. That's a no-no, right? All of our training says that. So you need to communicate with the patient, culturally sensitive in there, right? So that ability to bring in the third-party translation services, which we do, but can you also do that, right, in your video visit or in the other encounters, right? I think there's a real opportunity in that in these very multi-ethnic type of communities that are not primarily English speaking.
Yeah, the data problem. Well, it's not a problem. Data is so fascinating. I want to maybe expand on something you just brought up with different types of care, different points of care, and how those relate. We talk a lot about people operating at the top of their license, or people, physicians taking care of a lot of patients. We need to talk more about that, like the real expectations, instead of just like, what's the best value? Like, what does that even mean? I mean, I know about this, but it's so varied between each healthcare delivery system Maybe we could start with Jared here. Like, since you've seen many different groups, like, what do you see are standards of expectations or differences in how people approach that, like doing the best job you can or operating at the top of your license?
Yeah, that's an interesting question, and it does differ by payment model for sure, where you'll see in a fee for service, you're optimizing for the specialist to see as many patients as possible and get maybe even as many, try to triage to get those who need surgery to the top of the list so that they get surgery sooner. Where in a value-based model, you might see, how can we treat this person non-surgically as long as possible and deliver a good outcome? And so it's very different. But what's interesting is, I think what we've found, at least with DAX, is in value or fee for service, there is a rate limiter on the physician. And Ray kind of spoke to this, like, how do I make sure that somebody who is just here for a hypertension check, they go see the APP, and somebody who has multiple complex problems that need to be managed, they go see the physician. And what's been cool is to see that you can expand that physician capability to take care of complex patients by using a technology that helps them. And I think we'll continue to see this. It's all about the data. It's all about getting the data, and there's all sorts of interesting, and it sounds like Ray has interesting things he's working on, but there's all sorts of interesting companies and new ACOs like Aledade and big health systems like Kaiser and Optum who are trying to figure out, okay, like, how do we pull all this data from every source in the world and elevate these insights that we weren't seeing before, and giving them to clinicians at the right time to affect these people's lives and give them healthier lives, which I think is awesome. And what I love about that model is it is also moving into the fee for service space. It's not just staying in those value-based at-risk places, but it's brought this, like, health is the outcome we all want to the forefront. And physicians are kind of this complicated piece in there that help deliver all of that. And so enabling them, and what you brought up, Janae, is like, sometimes we think the billing hours analogy, we're not using physicians' billing hours appropriately at times. We're having them do low-level tasks.
My dad would be ashamed.
We're having them do low-level tasks when they should be figuring out, how do we take care of this really complex patient?
Yeah, I like what you brought up with data. Like, what do people do with the data alphabet soup? Stephanie, I know you have leadership there. Like, you've talked a lot. I don't know. Oh gosh, maybe not here, but I think you've spoken about, like, value-based care and fee for service, and your system uses fee for service, if I understand you correctly, but you're also very progressive with technology. So I wanted to hear, I bet everybody wants to know, like, how do you pay for that?
It is a great question. So the first thing I will say is it's not through endowments, sponsorships, and fantabulous payer mix. That is not how we're paying for it. I think it's a couple things. One, I think it is from the highest level, from our CEO down through the rest of our senior leadership team, a belief that putting our investments in technology that are going to transform the way we do the work is an investment that we need to make, and that's what's going to carry us into the future. We want to remain an independent health system, providing care to a rural, complex community. We're going to have to change the way we do things in order to do that, because some of the things that are mounting against us in any payment model strategy are not going to make that sustainable unless we transform care. So I think foundationally, again, having a senior leadership team that really believes technology is not just the add-on on the side. It's not just the way we get the bills out. It's not the way we get the note in the chart, but it really is foundational to care delivery, to good quality care and decision support and all of those things. That's first and foremost. And then I think it's about looking at ROI and again, having a great relationship with my CFO around the idea that these are going to be a little bit non-traditional, right? First of all, I'm going to pay for a lot of stuff, and I'm none of that revenue generated is going to come back into my cost center. So we have to have an understanding that I'm going to look like a big financial liability, but that there are downstream impacts to that. But then even as I look at, for example, DAX, in our organization, those kinds of products, we don't have that paid for centrally. It's not a one size fits all. Not every physician is going to love that tool. Some physicians are already extremely productive in the tools that we've already given them with Epic and Dragon Medical One and dot phrases and all the different kinds of templates they've done. They don't need that tool, and they feel good about where they are and how much time they're spending without it. So if you look at, for example, a scribe, which to Ray's point creates this awkwardness in the scenario, as well as, again, now we're paying a person to do tasks which can be automated, which we already decided is like the least effective and least cost-effective way to do it. Not to mention that they go on vacation, they have maternity leave, they get sick and can't be there, right? Technology doesn't get sick. Well, I mean, I guess we talk about ransomware and things like that, perhaps it does, but non-traditionally. And so, we've changed that viewpoint, and then we build it into their cost structure within their department, because that doesn't need to be overhead assumed by the entirety of the organization. So I think it is a little bit about looking at the technology that you're looking to invest in. And sometimes it comes to me, and sometimes I say, gosh, I think this is better justified in the practice. And what we have seen is our providers are seeing more people. They're telling me, I'm happy to see more people if I can keep this tool. Great, it just paid for itself. When we look at some of the other automation tools that we are starting to bring into the organization, again, this is starting to look at the ROI, and this has never been probably a better time to seize upon this. We can't find the people, and we can't afford the people. So paying for technology and making some investments so that, again, it's not just the physician who needs to see more people. Maybe the nurse ratios need to change. Maybe the respiratory therapist needs to be able to get to more patients across the hospital. Maybe we need to, we've got holes in all of these places. And it's an interesting time, because with automation prior, I think we were a little bit nervous to jump into this, because what people heard, even as we rolled out EHRs, people were like, you're going to get rid of my job. I'm going to get fired. Those people are gone.
The
no
robots
one is saying that anymore. I'm not saying we're going to fire anybody by bringing in automation technology. We're going to take the very valuable people we have left and say, we're going to make your job better and easier. And so it's a time that it makes it easier to have these conversations, because automation isn't seen as an enemy of the job. And again, you can do an ROI on the fact that that technology, once in place, forever allows that automation and that reduced friction and the higher value versus the human beings that we are churning through and unable to find. So that would be some of my comments. I mean, it's not a magic wand of where the dollars come from, but it's thinking through uniquely around, how to justify these things based on, well, if we are able to not have to bring in 7 people to do this work, how much technology does that buy?
Right. That's a great point. We need more people. Like, people are our most valuable asset, and we don't have enough people in healthcare. Ray, I'd love to hear your opinion, either on that, or maybe like on what's missing. Like,
I'll tag on to Dr. Lair. When I look at the value of what we're doing and how we're trying to introduce, the outcome, I think part of it comes to the culture of the organization, and we're committed to socially competent care, and social justice is at our core. And so when I work with the CEO and the CFO, and whether we're talking quality measures or what are the outcomes, we've raised our star ratings with multiple health plans from like 2.5 to 4 and 4+, right? And that's kind of that quality focus, right? And then the other type of health plan incentives, they come along with that as well. So I generally kind of look at a technology solution and what would be the outcome from a productivity perspective, whether it makes the job simpler, allows us to do things more effectively, it improves quality, ratings, et cetera. A different example would be on Medicare Advantage, on your senior services, how are you doing proper HCC RAF scoring, right? That's appropriate. And it's a huge opportunity, right? And you read the numbers, again, I'm getting a more managed care kind of the aspect, but it resonated so well. And even when you're looking at the interchange, we don't have hospitals, right? But we work with 15 different hospitals.
Mhm.
So how are we building those integration points around there? And again, that kind of comes back to the value-based care conversation. So I usually take my approach tied to that, or kind of on the journey of where we need to keep moving the organization. As a CIO, and I need to lay the track at least 6 months ahead of where operations needs to be. And sometimes operations often say, well, we're not ready. And I'm like going, well, I don't really care if you're ready or not. It's where I'm at. I tell my teams, I go, we're going to finish that upgrade. We're going to finish that there. We're going to deploy it to one department, and we're not going to, sacrifice our speed and all the stuff back up, because operations will push back on you and say, we can't do it. We're not ready on there. And I go, nope, you finish the work. We meet our commitments, right? And we keep delivering to meet the value requirements around there. So that's part of the approach that I do. There is generally a financial pro forma you need to tie to it. And then CFO is generally going to challenge you. And, the CEOs and CFOs never forget a number once you give it to them. So, you got to make sure you remind them of your assumptions, right, on what's tied to it. So that would be my input on that.
That's great. Yeah. We'll let the math people do that. But I like what you're saying about being prepared. Just for information, we're almost out of time. If anyone has questions for our panelists or about this topic in general, we'd love to hear from you. We also have a live Q&A at the end of the day. I'd love, Jared, if you could close it out and share either what you think is missing or what you see as the ROI on technology and artificial intelligence.
Yeah, I think honestly, Ray and Stephanie hit it pretty good. That you have to justify technology. You have to justify the cost. There has to be an ROI there. I love toys as much as the next person. Like, I love playing with the newest technology, and my wife could tell you how many old smartwatches I have. Like, every generation of every smartwatch. I have like 5 Pebbles and a bunch of just so many. And but in the end, in healthcare, we don't just play with technology for fun. We have to have technology that produces an ROI. And that being said, the other thing Stephanie said was, it's not always obvious. Sometimes the outcome, it's not just I added more patients. It might be recruitment. It might be physician burnout. It might be, it might be more patients. It might be better RAF capturing, HCC capturing and RAF scoring. It might be better prior auth. There's so many different things that we have to look at. And so as technology leaders, we actually have to be pretty creative. We have to be very knowledgeable, and we have to know all these different levers to push on. But yeah, these guys are amazing. Ray and Stephanie have been amazing to kind of talk through all this.
Yes. I'm actually grateful that I got to meet everyone and to hear your opinions about artificial intelligence, about technology in the future. Thank you for being part of this. And thank you also for your leadership in this space, because it's a lot of work. And like Ray said, not everybody's ready, but it doesn't matter.
Quote of the day: